And with that, I'm going to welcome Mary. Mary, thank you so much for joining us. This is our graduate seminar. There are many people online, so I'm just going to do my usual kind of introduction. This is our graduate seminar, and Mary Wiktorowicz, Professor Mary Wiktorowicz, is our guest speaker today. So welcome, Mary, and thank you for joining us. Mary is going to be speaking on global governance and antimicrobial resistance in a One Health framework. I will give a biography, a brief biography of Mary in a moment. But before we get started, I would just like to acknowledge the land that we are on. This is a hybrid event. And for those who are online, I just ask you to think about and acknowledge the land that you physically are on. So today here at York University Cuba campus, we are in Toronto, and this is a traditional Indigenous territory that is known as Takaranto, and we acknowledge its current treaty holders, which are the Mississaugas of the Credit First Nation. We also acknowledge that this is the traditional territory of many other Indigenous communities or Indigenous nations, and these include the Anishinaabe Nation, the Haudenosaunee Confederacy, the Huron-Wendat, and the Métis. And this territory is subject to the Dish with One Spoon Wampum Belt Covenant, which is an agreement to peaceably share and actually care for the Great Lakes region that we are on. And with that acknowledgement, I'd just like to introduce Mary. Mary is a dear friend. I think I can say that, with some confidence. Mary's a dear friend and colleague here at York, and she's a professor in the School of Global Health. She's also associate director of this institute, the Dahdaleh Institute for Global Health Research, and she's a member of the WHO Collaborating Center on Global Governance of Antimicrobial Resistance, which is here at York, and she leads a number of major projects, research projects, that compare the governance of antimicrobial stewardship across several countries and across continents to identify effective and equitable governance approaches to the governance of antimicrobial drug resistance. She also assesses the global governance of pandemic prevention to assist in identifying approaches that can foster the prevention of zoonotic emergence, disease emergence. And this includes measures, for example, like the regulation of wildlife trade. And her research also assesses global and state governance frameworks and underlying programs that support women's and children's health in sub-Saharan Africa. So Mary is very much an expert on global health governance, and I'm very much looking forward to her presentation. And I think just by the bio that I've read, you can see that she's deeply engaged in very practical issues that are front and center to global health. And she's also a leader in terms of how we think about governance in very particular domains. One Health frameworks, antimicrobial resistance, and women and children's health in sub-Saharan Africa. So Mary, it's great to welcome you, and please, over to you.
Okay, thank you, James, for that very kind introduction. So let me start by just sharing my screen. Okay, wonderful. All right, well, thank you, James, for the invitation to be here today. And the research I'm talking about today was basically a project that looked at the governance of surveillance of AMR and use of antibiotics. So we were looking at the governance of surveillance, and we did a scoping review that looked at what the key governance principles were. And in the end, we realized that, this whole concept of equity in surveillance seemed to be an afterthought, and that we really needed to explore this area further, and how could we make incorporating equity in surveillance more practical, more applied. And so we conducted some interviews. So this research was a joint venture, a collaboration between Arna Ruckert in the Global Strategy Lab and master's student Fiona Harris, Raphael Aguar, who's now a postdoc, and myself. So I'm going to introduce the research, talk about a political ecology framework as the theoretical guide to what helped us to frame it, talk about the interviews with global representatives from the Quadripartite, FAO, WOA, WHO, UNEP, and then from the data, we developed a conceptual framework, and I will then discuss what conclusions came out of it. So, as I mentioned earlier, this research didn't come from anywhere. We had done a scoping review earlier that looked at the key governance principles for AMR surveillance, because surveillance is basically tracking where is resistance happening and where is use and overuse happening. And in a sense, if you don't track the most vulnerable points, you're going to be missing them, and you're going to have an incomplete picture. So that's why equity becomes very important. And what we found through our scoping review is that equity was not only a domain, it was also equity was one domain of several, but it was also sort of a cross-cutting integral component of all other domains. So then what I'd like to explore today is, how does equity relate to AMR and antimicrobial use surveillance systems? Sorry. So the idea is to have it contribute to a conceptual understanding of the entry points through which equity can be embedded into AMR surveillance systems within the governance, and also to inform evaluation frameworks of AMR surveillance. Because, 1 year into a program of surveillance, you usually do an evaluation. Are you addressing, the key objectives of the surveillance, and so on? So if we don't include equity as a variable within that, then again, we're going to be missing it. So, and just so that we're all on the same page, the working definition of governance we're using is the commitment of independent representatives responsible for an area to reflexive self-organization based on dialogue and resource sharing to develop mutually beneficial policies and manage challenges in the face of complex reciprocal interdependence. We know that issues do not arise in isolation. There's often overlap. And so we need to look at, that kind of interdependence. And I really like the way Bob Jessup coined that. So just getting back to that scoping review, these are the governance principles that were identified in the literature for AMR surveillance. So the domains are participation. Often in political science, we refer to representation, because if you're engaged in governance, who's represented in the decision-making bodies? And so that's not just participation, but representation, collaboration, and coordination. And of those two, collaboration is important, but really, if you can get agencies to coordinate to ensure that, where one leaves off, the other picks up, that kind of thing, that's really important. And we see that with a One Health approach. We need to coordinate across sectors of human and animal health and the environment. Um, Management is an important governance variable. You need to, oversee and make sure everything is set up in the appropriate way, to make things, for example, transparent, accountable, and so on. So sustainability, making sure we have resources to continue to do surveillance in the future. Accountability and transparency. Once data is collected, who has access to it? Um, and who's accountable if we're missing certain areas, if we're not tracking, for example, AMR among vulnerable and marginalized communities, and we're not getting that data, there needs to be some accountability. And transparency, it can be a challenge because oftentimes when you're tracking antimicrobial resistance, and we all know that that can spread through pathogens across borders, countries do not want to necessarily share what is kind of a point of vulnerability or weakness for them, that their country hosts, pathogens that could easily spread. We've seen what happened during SARS and COVID-19, that countries, other countries shut their borders to those that harbor a particular virus so that it doesn't spread. And those countries will often try and sequester and not be transparent about it. So it becomes a very big issue. And again, back to equity. And you can see in this figure how equity, it's a domain in itself, and then it actually reaches into all of these other domains. Because, for management, are you managing in an equitable way? Is sustainability equitable? Is equity part of accountability and transparency and participation and representation? So it became one of these areas where we realized it's a term that's, bantered about quite a bit, but how are we actually going to measure this and track it? So in terms of background literature, what we found is that coordination is important for governments, organizations, and the private sector to coordinate efforts to ensure equitable processes and outcomes. Oftentimes, there are power imbalances, including insufficient funding, a lack of trust, and an absence of leadership to lead changes in establishing equitable AMR research partnerships. For example, in Asia, they created a secure data sharing platform and a regional governance body to build capacity, regulate, and lead research. And then, of course, we're all now familiar with this term of One Health. That's important to promote a holistic collaboration across sectors that allows us to coordinate data and resource sharing at the global level. So we saw during COVID-19 wastewater surveillance, and that typically has not been done for resistant pathogens. But now that it's been happening with COVID, this is a model that is starting to be emulated for AMR. Unfortunately, in Ontario, we had a COVID-19 wastewater surveillance system that the provincial government has basically shut down, which is really unfortunate because, the groups involved in AMR surveillance in the environment and wastewater, they're all very interested in using that as an approach. Again, it's a One Health approach, and if we don't track all of the sectors, we're not going to be getting the full picture of what's going on. We're not going to be getting the early warning systems, the sentinel systems that we need in order to prepare ourselves and address some of these pathogens. And we also found that a political ecology theoretical lens would be important to assist in conceptualizing and supporting the operationalization of equity in the governance of AMR surveillance. And political ecology, basically, we talk about the importance of just societal relations with nature. That we need to be more enlightened in how we treat nature and understand that we are part of nature, and we have to respect boundaries, for example, with wildlife, because wildlife has viruses that, they have immune systems to adapt to them, and we don't, as humans. So we have to be careful and not, over encroach on their territory, because then their viruses, like the ones that spread from bats and caused COVID, they could spread to us. So again, that's why we're using this political ecology lens. So we take a broader perspective, because global inequalities and the compounding effect of systemic threats to global health shape the global health systems and outcomes. But there are also constrained health systems and resource challenges that can create hurdles to the development of One Health surveillance systems. And it brings the impact of health issues and the inequalities and the systemic threats into relief. So now getting on to our methods and our data. So 17 key informants shared data through key informant interviews between March and June of last year. And as I mentioned, they were from the major international organizations such as the WHO, WOA, FAO, UNEP, as well as some national governments, university experts, and the private sector. And it was basically, these folks were from sectors involved in AMR surveillance. So that's both human, animal, and environmental health. And so our coding structure, how we analyze the data, basically helped us to conceptualize surveillance in a more holistic way and look at the context, appropriateness, and feasibility of conducting surveillance and the data, how to access, analyze, display, look at data from an interoperability perspective. If you have AMR data in hospitals, can the surveillance in, for example, animal agriculture talk to those? Can those data systems be interoperable so that we can summarize what's going on? Who owns the data? And how can there be transparent access to it? Then there's this concept of framing and common definitions. We find that veterinarians often look at resistance from a different perspective than medical doctors, environmentalists. So it's important for everyone to have some common definitions so that we can speak the same language. There's a global redistributive dimensions. We know the global south has fewer resources, and that has implications for testing and detecting AMR and for tracking it through surveillance. And what is the impact of inadequate surveillance on marginalized and vulnerable groups? And, that itself is huge. And then sectoral balance. How do we ensure that we do surveillance across all of the One Health sectors? And there is a temporal element of equity, because we have to incorporate equity in the planning, in the implementation, and the evaluation of surveillance. And oftentimes, we have technical people involved in surveillance. So epidemiologists, sometimes MDs and clinicians, sometimes veterinarians who are depending on the sector. But we often don't have social scientists who often bring in the ethical, the social perspective. And that's why equity dimension is often not included. And you'll find that in the interviews we conducted. And so I'm sort of racing to the end first before getting through the interviews, because we came up with this conceptual model of equity in AMR surveillance. That going from left to right, even when you conceive of surveillance, you have to think about equity, because you have to think about, can we track AMR in the marginalized groups, taking into account socioeconomic status, access to antimicrobials, the global north and south divide, the global redistribution of resources, the social determinants of health, um, funding, sectoral balance, capacity building. We have some NGOs such as the Fleming Fund, funded in the UK, that go into sub-Saharan Africa and Asia and try and set up labs for detecting AMR. And we have other NGOs as well who are on the ground in low and middle income countries to try and support the infrastructure needed to do that kind of testing and understanding the spread of resistant microbes. And as I've said earlier, we need to all be on the same page in terms of the definitions. When we use certain language, what do we mean? Are we speaking about the same thing? Context appropriateness, feasibility, and then there are all the concerns around data, the access, the ownership, how do you display it, its interoperability, data literacy. Oftentimes, policymakers do not understand the data, and so it has to be translated into bite-sized pieces that, what significant statistical significance means and what the implications are, for example. So on attention to equity deserving groups, one of the key informants said that, I'm afraid that we've not really paid a lot of specific attention to this aspect of equity. To be really honest, we've not specifically considered that. Whoops, back. And in terms of the social determinants of health, another key informant indicated, but then what we're really completely missing is to dig deeper into the structural causes that are actually pushing the development of antimicrobial resistance and use in the first place. So, the structural causes, and those are things that relate to equity. So surveillance, in a way, these key informants said we had to back up. We're looking at the prevalence of resistant microbes, but we're not tracking the root causes of AMR. So this key informant said that there's a big gap because we're not doing surveillance of the reasons for which antibiotics are given. So we're not looking. And if we're not looking, we're not seeing. So things like sex and gender, social determinants of health, geographic location. Is AMR more prevalent in rural versus urban contexts? What's happening at the antenatal care period? Sepsis. Animals and humans are vulnerable to sepsis, which is an infection that spreads throughout the body. So, we have to be able to track these things in all sectors of society. So another key informant said that, and when we talk about surveillance, we should really be doing health surveillance and not resistance surveillance. So we should combine the information about antimicrobial use with the information about the health status of the population. And that will tell us a lot about who's most vulnerable to resistant pathogens and where are they. And sometimes the problem is, not just AMR, but actually access to antibiotics, that those are not accessible everywhere that they're needed. So another key informant said that on the global north-south divide, we went through several iterations, and that is of their surveillance framework, partly because a lot of developing countries felt that we were aiming too high, putting something in place that was completely impractical for many parts of the world. They would never have the resources to do it, and it could reflect badly on them. So, it's almost as though you have to meet people where they are and, in their context, and adapt to that context in terms of the resources that are available, and so on. And, they may not necessarily have the funds to develop, the traditional epidemiologic kind of lab testing that we have in the global north, But now there are innovations in point of care technology and rapid diagnostics. And just like a lot of low income countries did not even set up landline phones, they went right to cell phones. Maybe we can do that with surveillance, with, using these quick point of care diagnostics. But in any case, we fund it. That's why we need to think about the redistribution of resources. Another key informant note. So they're talking about financial support to develop the activities, protocols, guidelines. So now when they are discussing in the G7, in the G20, all the scenarios that they consider can be attracting this financial support. So we've seen that in the pandemic agreement. There's going to be a pool of funding to enable low-income countries to access funds to access vaccines. I think we need a similar kind of fund for low middle-income countries and their populations to access antimicrobials and to access the diagnostics that will allow them to track resistant infections. So in terms of capacity building, another key informant indicated that I think we really look into lab detect AMR to then have an impact at the stage potentially to be able to provide information that then leads to tackling the issue correctly. And that would fit in that moment. So help, identify. Often we have suburban slums where the appropriate water and sanitation systems are not in place. And that in itself is even more important than having access to antibiotics in a way, because that, if you have clean water and sanitation, that can prevent the spread of infections. Not that you don't need the antibiotics, you need those too. But those are actually being overused because we don't have that wash infrastructure in place, kind of as a band-aid solution. So it's an issue. So another key informant said that the flow of knowledge and learning is not unidirectional. They discussed how they took lessons on participatory governance from Africa and the Caribbean back to Europe. So, we really need a north-south dialogue. We need capacity building. We need sectoral balance. But we need to keep this frame of equity in mind always when we're moving forward. And in terms of feasibility, global guidance can provide norms that shape national approaches to AMR surveillance, but they're not appropriate for all and often poorly resourced countries, which can then set them up to underperform. So, as I've suggested earlier, we really need to meet them where they are and take into account what the local capacities are and how they could be, ask the local countries how they could be, how they want to be supported to best move forward. So another key informant said that I like the word balance because that's what it needs to be between what you can do in a society compared to what is possible there. So striking a balance among countries with such disparate levels of surveillance capacity is really difficult. In terms of feasibility, building an AMR element into existing infrastructure or piggybacking on related systems. For example, if you're doing wastewater monitoring to tackle polio or environmental monitoring of persistent organic pollutants, those systems could be, used for AMR as well, especially if you're doing environmental monitoring. You can monitor different kinds of things in the wastewater that you're collecting. You can monitor not just for environmental pollutants, but you can see if you can culture the water and see if there are any resistant bacteria there. And given an increasing digital divide, useful technologies, new and old, that don't require large investments was highlighted. And in terms of human resources that we know are crucial, one key informant said that if you have a good coordinator, you have a good surveillance system. If you have a bad coordinator, you have a bad surveillance system. And if you have no coordinator, you have no surveillance system. So it's kind of stark language, but I think the point is often there isn't funding to hire a coordinator to oversee surveillance systems, and that's a real issue. And in some sectors, intersectoral work was not considered part of their core activities and only occurred when extra time or resources were available, sort of off the side of someone's desk. So, something that was suggested was that a key strategy would be for sectoral counterparts from the human health, animal health, environmental sectors to designate a focal point to liaise with. So folks know who to reach out to if a problem arises. So taking time to develop relationships and offering opportunities to influence the surveillance system proved very effective. Oftentimes, just getting folks to, the key sectoral counterparts to talk to each other to understand what's going on in the different sectors was very important. So another key informant indicated that one of the main challenges they see is that, well, the food and agriculture component of the National Action Plan for AMR is kind of neglected as compared to the human side. So it means that the portion of funds allocated to food and agriculture is always much less and much more unsustainable. And that's a problem because, you know, um, bacterial pathogens that are resistant to antibiotics, if they spring up in the animal sector and animal agriculture, for example, they can spill over into the human sector. There can be that emergent zoonosis. So, the tracking can't be done in isolation. It really needs to be very well coordinated. And in terms of framing and common definitions, another key informant said that no system currently exists that takes in that diversity because we are using similar words to say completely different things. So, how the root of the problem is viewed and the best ways to address it can be very different depending on which sector you're in. But oftentimes, one sector tries to impose their definition on another sector, and we refer to that as epistemic violence. So, a forced delegitimation, sanctioning, and repression of certain possibilities of knowing, going hand in hand with an attempted enforcement of other possibilities of knowing. So, we need to understand how terms are being used because, terms are used to frame a problem, and we need to understand a problem from a very holistic sense. And there were, the key informants did indicate there were data concerns. So one suggested that it's important that the countries, once they collect the data, they're willing to share it, and that there's no fears or concerns about openly sharing it. And as we know, it's easy to say, complex to do. Countries have, I understand the reason. It's like trade reasons, health reasons. There's political reasons why countries might not want to be transparent about, an emerging AMR problem, for example. So I think with all those, the analysis we did, we were able to pull together this conceptual framework of how equity really needs to be incorporated, even in the planning stages of surveillance, so that you ensure that, the relevant sites, those that monitor marginalized populations, those that include the environment, and other vulnerable points of contact, that they're all included. And I think you need the technical scientists, the medical, the agricultural, but you also need the social scientists because I think, as James, you were saying earlier on, you're telling a story. The data tells a story, and you need that social science lens on it too to understand the bigger picture and the social implications. So that came through quite a bit. So, in terms of our discussion, the key aspect in the literature on equity and AMR is there's a need to map the inequality in order to address the equality of chance. Issue of data representativeness is key to enable accurate framing of the causes and the consequences of AMR. If we see that AMR is rising in suburban sort of slum areas where they don't have proper sanitation, well, the solution really is to have better water and sanitation in those places. But if you're not tracking it there, you're going to miss that. And then funding models for research and surveillance are also different. Sometimes, a low-income country will have a donor, a high-income country, and they will offer some project funding. But pilot projects are insufficient. By virtue of its definition, surveillance has to be continuous. It has to be tracked on an ongoing basis. So pilot funding or short-term project funding does not cut it. You really need continuous funding. So in the end, what we found was that explicit consideration of equity was absent in the governance of AMR surveillance. That could be due to the limited inclusion of social science perspectives. AMR can't be addressed without understanding its root causes. And what we really need is systems analysis to inform the agenda, to take the bigger picture into account, understanding the root causes. And then we can, understand how and why equity elements need to be incorporated within surveillance systems. So this research had some limitations. Only key informants from high-income countries were included. There was one key informant was from a low-income country, but most of the key informants actually had experience in LMICs. So either they were based in an LMIC, for example, working at the FAO or the WHO or WOA. The other thing is that the research did not consider intergenerational equity, which can't be ignored given the ramifications of over and misuse of antimicrobials. As AMR can't be solved, it can only be managed. And so from a political ecology lens, recent calls have been made for systems level interventions to improve water sanitation and hygiene, infection prevention and control, mass vaccination. All of those preventative things need to be in place. But what we're seeing is that current interventions are often framed from a biosecurity lens instead of from a collective structural responsibility lens. Because really it's imperative to address the socioeconomic factors for antibiotic consumption that threaten their viability. If you have groups that don't have access to wash, then they're the ones where the resistance, the cholera, and other kinds of infectious disease are going to be spreading. So surveillance and data linkage can support these efforts by helping to identify where are the key areas that really need to be addressed. And so in terms of key takeaways, equity must be a focus. Using a political ecology lens that emphasizes the collective structural responsibility, the attention on root causes of antimicrobial use and resistance, and the social determinants of health that shape access to antimicrobials and the likelihood of developing AMR. The assessment of root causes is largely absent from AMR surveillance evaluation tools, but we're starting to see it, and we're starting to see more attention on this issue. So there are a whole series of evaluation frameworks for AMR, and honestly, none of them included equity in them. So now, hopefully, with our research, getting it published and out there, hopefully the developers of surveillance systems will be more attuned to including equity elements. And the importance of data. So data concerns, data linkage, and sectoral balance arose in almost every interview. What we really need is to build trust between sectors, disciplines, and countries to enable the transmission of useful and usable data. Because in the end, AMR is a global commons issue, and we need the global redistribution of resources to build capacity while recognizing that we can learn from the work occurring in both high, low, and middle income countries. And I thank you for your attention and happy to answer any questions or if you have comments, very happy to engage.
Great, Mary, thank you. Mary, thank you for your presentation. We have a question. Go ahead, Mike. Oh.
My question relates to the definition of equity in this study. So, for example, to just give some context to the question, in global environmental governance, equity is defined more or less in international law on the basis of premised on ideas of distributive justice and procedural justice, which then is incorporated into the UNFCCC, which more or less is used legally to differentiate between contributions and responsibilities to climate change. So that's I don't know, based on with AMR, the definition of equity, where that is premised.
Yeah, it's a good question. Yeah, we would, I mean, and it's something that we should define. You're absolutely right. And I would agree with you that we would probably take the same definition that you're referring to that's being used in the Sustainable Development Goals and other legal frameworks.
Go ahead, Rochelle.
Hi, Mary. I had a question about the idea of the equity deserving groups, and I thought it was interesting in that diagram that you had positioned it between sort of the conceptualization of equity and the collection of data, because we know that there is a data gap from underrepresented groups, and I was wondering if you could sort of elaborate on that sort of definition of equity deserving groups.
Yeah, well, I think equity deserving groups are the ones that are marginalized and neglected, and often they aren't tracked at all. And I think that's why, we're bringing to light that this whole concept of it's not just AMR that we should be tracking. We should be tracking the whole picture of health, because if we don't, then we're missing some key, if we're, for example, I think one key informant said, if we're only tracking the AMR of people that come to a hospital in an emergency, then we're not tracking what's going on in the community. We're missing the whole picture, potentially it's being spread within a community, and maybe only a fraction of people in that community are coming to the emerge. But what's actually going on in that community? Is there some kind of zoonotic emergence happening? If we don't track those vulnerable and marginalized and often invisible communities, then we're not getting the full picture. And I think it also speaks to this concept of, instead of just focusing narrowly on biosecurity, if we address the concerns of these equity deserving groups, biosecurity will take care of itself. So, I always think of biosecurity, yes, it's important because you need to track it, but it's often a term used on farms, to make sure if there's a particular infection spreading, to prevent it from spreading any further. But what about in the community where these things can spread and no one's tracking them? And that's why I think our lens has to shift. And that's why, and thank you for pointing that out, this concept of equity deserving groups being between those 2 points of conceptualization and actually gathering the data.
Thank you.
Go ahead, Naima.
Hi, thank you, Mary, as well. I think the question I was wondering during this presentation was on what are the different barriers or issues that you've identified, like as you've engaged with countries, for example, in sub-Saharan Africa specifically, you know, in terms of like launching or piloting or developing this kind of work.
Sorry, I didn't hear the very last part of your question in terms of developing.
Yeah, just like in terms of like AMR resistance work, like how, like what are the different challenges that you've come across in terms of collaborating with either local governments or local health authorities?
Yeah, well, thank you for that. Yeah, well, oftentimes the infrastructure is just not there. And as one of the key informants said, often you will track it in the health sector because within a hospital you will have a diagnostic lab, or, you know, the labs will be associated with acute care. But, you know, in the animal sector, especially in low and middle income countries, they don't really have access to the labs. So you don't necessarily see what's happening. And I think that kind of coordination, and it's less well funded. You know, I had done some other interviews with folks in the World Organization for Animal Health, and they indicated that WOA, their organization, is not a UN agency, and it basically receives contributions from, you know, countries like Canada. They were very happy that I was a researcher from Canada because Canada is supporting WOA. And WOA goes into countries and helps them with their animal surveillance. So, you know, you have, you know, these multilateral organizations who are working and trying to support what's going on, what's happening on the ground. But there is a really, a very much an acute shortage of lab capacity for both animal health, environmental health, and even human health outside of acute care hospitals. Um, so yeah, that if you don't have that infrastructure, or if it's a sort of a fledgling infrastructure, then and it not well staffed, you're not going to have time for that staff to coordinate activities across each other and to learn from each other and communication systems. So, you know, on a farm somewhere, is it purely in animals, or is it a zoonotic infection? So, yeah, coordination, it continues to remain a huge issue, and yet it could solve a lot of problems if we only had it. But it's often an afterthought. So, you know, and I think even at the global governance level. So it's only during the pandemic, the COVID-19 pandemic, that the quadripartite was formed. So, you know, even though how COVID emerged through the main theory is a wet market in Wuhan, China, that it emerged as a zoonotic illness from likely bats to humans in a market. You know, that's kind of a veterinary issue, and yet WHO, the World Health Organization, has is being given sort of the lead on governance, and until it connected to WOA and FAO and UNEP, you know, it didn't really have the full picture of what was going on. And so you need that One Health coordinated approach. So that's at the global level, but you also need that happening on the ground in each country, in each region of each country. So, you know, it's, and there are some studies that are starting to emerge looking at coordination, but it's definitely a challenge. And I would say for equity, it's also a real challenge because, you know, as I've said, it's understanding where the vulnerable points are is kind of the key. And if you're not tracking them, it's yeah, it can lead to a problem to grow much bigger before you can, shut it down. So thank you.
So Mary, I have one just comment, and I'd love your reflections on it before we close out the seminar. I'm not quite sure how to formulate this, but I'll give it my best shot. Just listening to your presentation, which was really good, very comprehensive in terms of defining an approach to equity in antimicrobial resistance. What it seems to me is being revealed, aside from the issues you've already identified, at a bigger level, what is being revealed is the aspiration-rich and policy-rich approach to global health and to governance that is actually capacity poor and in many cases delusionary. So that we have, there are vast areas of the world where organized health surveillance is it's just simply not, it doesn't exist, right? And we can say it should, it could, it might, but it doesn't. And that's just one example. And it seems to me that the governance of AMR, and especially the governance that considers equity as a kind of a core principle, it's actually revealing just how egregiously inadequate our practical approaches to practical problems of the global commons, how egregiously inadequate those approaches are. And as you were speaking, I was thinking, climate change, data security now in the age of the AI revolution, the idea of the public good, like where is that? And how is that even expressed and then pursued around challenges of the global commons? And it also struck me that that very nice sort of dichotomy you painted between a biosecurity lens and a collective structural responsibility lens. Obviously, I think what you're implying is that the collaborative structural security lens is the better one because it accounts for the public good and the good of the global practical approaches to challenges of the global commons. And so there's that, and then the other is that the other sort of big idea, whatever, response is that antibiotics are increasingly precious because the research and development pipeline is increasingly empty, right, for antibiotics. And that's another failure of public goods, of the pursuit of public goods. We rely almost entirely on private sector actors to ensure that pipeline is being properly fed. But as the pipeline diminishes, then the antibiotics that we have become even more precious. And as we use those irresponsibly in a system of non-systems, which is kind of how I would describe what you've described. There's no system there. It's a system of non-systems. The more we continue to use antibiotics in that system of non-systems, the more rapidly we accelerate the emergence of antimicrobial resistance, and in terms of intergenerational equity and intergenerational justice, I'm thinking of, as Indigenous peoples think, what about in 7 generations from now? What do we need to do today in order to protect that precious resource of antibiotics for the future? Because if we continue on our current trajectory, I haven't seen any models of this, I haven't looked actually, but if we continue on our current trajectories, the really catastrophic scenarios that are being painted around 30 to 50 million people dying because antibiotic within, I think, what is it? How many years? What is that? 2050? What do they say?
Yeah, 2050.
2050.
Yeah, 2050.
Yeah, because antibiotics are just no longer, they don't exist anymore, right? Because they're no longer useful. That's a terrible scenario. Like, that's really bad. And that's 1 generation from now, right? So if we continue doing what we're doing, we're actually accelerating that loss of a very precious resource. So it seems to me that we as you know, we have to think about the future, right? And future generations beyond ourselves, and we also have to think of how to preserve, first of all, existing antibiotics, their effectiveness, and also how to feed that pipeline of research and development. And so I think I'm just thinking of different governance responses to that framing, right? And I'm thinking of something I was involved in some years ago with the WHO. It was around multi-drug resistant tuberculosis. And so essentially what we did was we recognized that there was the emergence of multi-drug resistant tuberculosis and that we needed to be able to treat this. And there is an existing treatment for MDR-TB, but it's very expensive. And the drugs are very precious because if they're used inappropriately, there will be drug resistance, right? And then you'll have nothing, right, to treat MDR-TB. So, the treatment for standard TB is about between $60 and let's say $180 for the antibiotics, for the full treatment, right? Just for the antibiotics, never mind the infrastructure and everything else. And if people don't complete their treatment properly, and there's many very good reasons that people stop their treatment because of inequity, because of structural, frankly, violence against people that force them to go back to work prematurely and not finish their treatment, right? And in that context, drug resistance can emerge, and that's kind of what happened. That's how MDR actually emerged. Now, the treatment for MDR is about $200,000 per patient, right? And it requires 24 months of in-hospital care. So the drugs alone are $200,000 plus the infrastructure and so on to actually deliver. Now, we don't want to get into that situation generally with many other diseases. So what we did was the WHO with MSF and with the International TB Alliance, we created what was called the Green Light Committee. And so access to the treatment, to the drugs for MDR-TB could only be granted through that committee, right? And part of the assessment in terms of actually giving not an individual patient, but giving a doctor or a healthcare system, not a system, but a doctor in a specific clinic or a specific hospital. It was really down to that level. The part of the assessment was, do you have the capacity to ensure full appropriate treatment, right? And to absolutely ensure it, right? Because we cannot lose these drugs, right? And that was actually quite effective. Now, it was a very different approach to governance instead of a bottom-up approach because of the value of the medicines. I don't mean their market value. I mean their social value, right? Because of the value of those medicines, it required a very different way of approaching the problem, given, for example, what you have brilliantly, Mary, frankly, illuminated, right? You've described this system of non-systems. And so I'd just like to hear your thoughts on that.
Thank you, James, for highlighting so many complex issues related to AMR and AMR surveillance. That's I really like the green light committee you suggested, but you're absolutely right. Sort of the systems we have in place. I mean, we don't really have systems for determining access in the sense that in many low and middle income countries, you access antibiotics over the counter or you access fraudulent ones on the streets. In our own countries, we misuse them in agriculture, for example. I know in the cattle sector, they, once calves are weaned and sent off to these feedlots, they're basically kept on antibiotics because it's how they treat them is so inhumane. I mean, anyways, I'm not going to go into that, but they're treated very inhumanely, and then they're very vulnerable to infection, and they do develop it because they're in such a fragile state when they're transferred to those lots. So I guess where I'm trying to go with this is you're absolutely right. We do not have a system for better determining who gets access to, as you say, this precious resource, because our children and their children, will they have access? Will they be, right now, 26% of the time, antibiotics are not effective to the first line treatment. So by 2050, that's going to be up at 45% or 50%. So, if antibiotics only start working half the time, that's an issue. So I don't know what to say about, your suggestion about something like a green light committee. Clearly, that would be very important. I mean, I suppose we could look to the climate change sector where, carbon, there's a price on carbon. And so when we go and fill our cars up at the pump, we pay a high tax for, for gasoline. Well, maybe antibiotics need to be priced at a higher level so that they're used more judiciously. I don't know. I think we do need to come up with models because a lot of the Western world is banking on innovation to save us. But really, stewardship is what we need. And I think the other thing is, in a lot of countries, the sanitation systems could prevent a lot of the problem. But, if the kind of money that we're putting into developing new drugs could be put into, even a fraction of that could be put into sanitation systems, a lot of the problem would go away. So, I think it's very complex.
I think it is complex, but thanks for just giving us a range, and not a complete range, but a range of policy options. And I would just say that I think one of and it's not an attack on you, Mary, but it just sort of more generally, one of the challenges that global health people face, that they often don't know they face, is the challenge of false dichotomies, right? That we either put money here or we put money here, right? That this, if we do it here, well, then it will reduce the overall problem more effectively than if we put it here. Well, for example, the example you gave, we put money, if we took a fraction of the money that is or should be ostensibly going into R&D, and put it into water and sanitation and hygiene, well, then that would have a positive effect, right? I think that's a false dichotomy. And I think in the sense, because there are limited resources because we choose to make those resources limited, right? There's a limited amount of money that is available for water, sanitation, and hygiene because we choose to make it limited, right? There's a large amount of money available for R&D, ostensibly, or at least in theory, right? Because we choose to do that, right? Now that's a choice, and now that is not a law like the laws of thermodynamics. You know, that it's either this or it's that. That's not how it works in terms of human policy and how we construct our social visions and actually enact our social visions. And I just would, you know, I've only got another few weeks here with this group of students, and they're a great group. My God. So I want to kind of give you as much of my little thoughts as possible, and that's one of them. So thanks for giving me that opportunity, Mary. And also, Mary, thank you so much for your presentation. You really did illuminate an incredibly complex area, and you did it in a highly intelligible and meaningful way. And thank you so much for doing that. And I think if you can successfully publish that quickly, which I think you will have no trouble with because it's really good, you know, it will be a huge contribution to how we understand the complexity of AMR as a global health governance challenge. So, Mary, congratulations on the research. I can't wait to read it in published form. And thank you so much for presenting today.
Well, thank you, James, and I appreciate, yeah, we should not set up false dichotomies. We need to make the right choices, but anyways, yeah, thank you, and I really appreciate the comments and questions. So, okay, well,
Excellent.
take care then.
All right, Mary, we'll talk soon.
Thank you.
All best. Okay, let's take a 5-minute break. Sorry, for those online, I don't know if anybody else. Okay, for those online, thank you so much for joining us. And we will have our seminar at the same time next week. And we will be very lucky to hear from Professor Jeannie Samuel, who will be presenting on participatory action research methods for community-based emergency health responses in Latin America. And I really urge people to join because that's actually a really, really, it's a unique combination of how to, of a methodology that is typically used in so-called development context. But what Jeannie is trying to do is shape it so it's actually relevant to emergency context where decision-making needs to be rapid and needs to be immediately responsive. Far less deliberative and more responsive in an emergency. And so this is a very, very interesting and exciting, intellectually exciting combination of themes and ideas. And so I very much urge people to join us next week. And with that, we'll close our seminar for today. Thank you.